Hello, my name is Vince Greenwood. I am the director of the Washington Center for Cognitive Therapy. In this talk, I'm going to try to answer the question, what is cognitive therapy? I feel privileged to do so because cognitive therapy has become the leading force in the development of research-tested, effective treatments for a range of painful mood disorders. A number of studies have shown that mental ill health causes more of the suffering in our society than physical illness, poverty, or unemployment. Fortunately, over the past 20 years or so, there has been a revolution in the mental health field. It is no longer the case that we don't have effective treatments for many psychological difficulties. We do. The bigger problem is getting more clinicians trained in these effective approaches, getting the word out that such treatments exist, and disseminating the treatment to more people in need. I'm going to talk a little bit about the origins of cognitive therapy, how cognitive therapy differs from more traditional therapy, describe the cognitive model of suffering, particularly as it applies to clinical depression and anxiety disorders. It's the scientific understanding of these difficulties that has resulted in devising helpful treatment programs for them. And finally, to give you a thumbnail sketch of cognitive therapy, what the experience of a course of cognitive therapy might look like by taking you through the stages of that treatment approach. Now, cognitive therapy emerged in the 1970s, at which time there weren't any scientifically validated treatments for psychological disorders. Perhaps the major pioneer of cognitive therapy is Dr. Aaron Beck at the University of Pennsylvania, who was trained as a psychoanalyst. That was the dominant therapy model at that time. But he became frustrated with that treatment in his work with patients suffering from depression. He began developing a theory and treatment that was in contrast to the traditional approaches of that time. Psychoanalytic theory highlighted the childhood origins of psychological difficulties and felt it was necessary to gain insight into those childhood difficulties in order to cure them. Cognitive therapy, on the other hand, focused on the client's current conflicts and symptoms, as well as the situations in the patient's life that were linked with stress. Psychoanalysis believed the primary causes of emotional pain were unconscious forces that required the expert excavation of a trained therapist to bring them into consciousness for change to occur. Dr. Beck, in his work with patients, turned his attention to what they were actually thinking in the session, helping his patients observe the thoughts that were part of their thinking style. With his patients, his depressed patients, he discovered their thinking styles were overly harsh and self-critical, pessimistic. To help his patients, Dr. Beck encouraged them to examine their thoughts and how they might be biased or distorted. Traditional therapy did not focus directly on a client's symptoms or self-defeating behavior. They believed such behavior and symptoms would just wither away if you could just bring to light the conflicts that began in childhood. Whereas cognitive therapy, also called cognitive behavioral therapy, often focuses directly and quickly on the behavior patterns that go along and often reinforce most difficulties. In that sense, cognitive therapy takes advantage of a revolution in the field of psychology in the 1960s called behaviorism, which brought to light the importance of behavior and psychological problems, and more importantly, principles of behavior change. Dr. Beck and his colleagues, no doubt bolstered by their clinical success with patients, developed a cognitive model of suffering and psychological disturbance. This model, first and foremost, is based on the scientific study of suffering. Instead of hypothesizing what, for example, might cause clinical depression, they examine the actual experience of individuals suffering from depression. What thoughts, feelings, and behaviors made up the depression. The cognitive model of disturbance, in its most crystallized form, has three basic principles. The first, as mentioned above, is that thinking, not mysterious, unconscious thinking, but conscious thinking, plays a large role in creating and maintaining emotional suffering. Thoughts that are important to understanding suffering don't require deep sea diving to be understood. they are more like the ocean we swim in. The second principle, also not surprising, is that the thinking is negative. Researchers and clinicians were able to pinpoint the thinking patterns that go with particular disorders. One of the first disorders cognitive theorists turned their attention to was depression. They discovered that individuals with depression had a constellation of negative thoughts about themselves, the world, and the future, what Dr. Beck coined as the cognitive triad. Individuals with depression have a strong tendency to view themselves as inadequate, defective, and worthless, to view the world as frustrating and depriving, and to view the future as hopeless. And when cognitive theorists turned their attention to other disorders, they discovered negative themes, different themes for different disorders, but negative. For most anxiety disorders, for example, the individual perceives some kind of major threat that they feel they cannot control. Now, the third principle is the key one in terms of opening the door to treatment possibilities, which is not only is it that conscious thinking is largely responsible for emotional suffering and that thinking is negative in a particular way, but also that it is what we call distorted, that it is not accurate or a true reflection of reality. Furthermore, and this is another key point, the distorted thinking, far from being in the service of protecting the sufferer from pain, that was a psychoanalytic view, that we have these defense mechanisms, rationalization, repression, and so on, which distort reality to protect us from emotional pain. What we discovered was that the distortions in depression, anxiety, and other mood disorders add to the pain. The thinking distorts reality in a negative direction and is a major contributor to emotional pain. Cognitive therapy, the treatment approach, flows from our understanding of the central role that thinking plays in psychological difficulties. I'm going to try to give you a picture of how cognitive therapy is conducted. Cognitive therapy is collaborative. The client and therapist together identify the targets of therapy, usually a combination of reducing painful symptoms and realizing important personal goals. Cognitive therapy is focused on the present. It's short-term. Most therapy programs are in the neighborhood of 12 to 15 sessions. Most of these treatment packages can be thought of as having 3 stages. The first stage we think of as an assessment or self-awareness stage. Here we pinpoint the feelings, thoughts, symptoms, and behavior that make up the disorder, the raw data of the suffering. We also identify the situations, what we call triggers, that go along with or evoke the painful feelings. We ask clients to fill out daily mood and thought records to help with this process. Now, the painful feelings are usually easy to identify. These feelings are usually front and center in the client's awareness and are typically the reason one is seeking help. To identify the important thoughts can require some guidance from the therapist, some self-awareness training. Again, not because the thoughts are mysterious, but because in suffering, we are keyed into the feelings and may need to direct our attention to the thoughts that are closely tied to these painful feelings. Again, with depression, we almost always find self-critical thoughts and pessimistic thoughts. With anxiety, we almost always find interpretations where the person believes he is in danger. Identifying the thoughts that go along with suffering can have some immediate payoffs. First, one begins to get a little distance from the painful recurrent feelings. Instead of being swept away and feeling hopeless or scared or furious in the case of anger, they are able to stand to the side a bit and observe the suffering, which can have the effect of reducing it somewhat. Second, one begins to see the key role that one's thoughts play in the suffering. They see how important and consequential their thinking is, and this can give them hope. Since they are, to some degree, the author of their upsetting thoughts, perhaps they can rewrite the negative scripts in their head. In this first stage, we also identify the behavior that goes along with and maintains the disorder. In depression, this almost always involves withdrawing from activities that the individual feels might give them either a sense of accomplishment or enjoyment. Unfortunately, that withdrawal reinforces the thinking that one is inadequate or useless and life is bleak and devoid of pleasure or fulfillment. In anxiety, the behavior involves avoiding situations the person feels might be dangerous. Depending on which anxiety disorder, these might be external situations, giving a talk or going to a party in the case of social anxiety, avoiding places where they might feel trapped in the case of panic disorder, or internal, where one's own thoughts and feelings are seen as dangerous and must be avoided, often the case in post-traumatic stress disorder, or shameful and must be undone, as in the case with obsessive compulsive disorder. The second stage in a course of cognitive therapy, after we have identified the essential components of the client's difficulties, the second stage is where we impart and teach change strategies, depression management skills, anxiety management skills, and so on. The central skill we call cognitive restructuring, which is learning how to question, challenge, and change the negative thinking that fuels the disorder. There are many techniques and strategies to help clients counteract their negative thinking. We often start with helping people identify the particular distortions in their thinking. Examples of distortions might be to think in all or none or black and white terms. For example, a person with depression who didn't do as well as he wanted on a test might think, I'm a total failure. A person with social anxiety might think, no one attractive will ever go out with me. Fortune telling is another distortion. This is where you go into the future in your thinking and make a negative prediction. A person with depression who is not advancing in his job as much as he would like might have the thought, I'll never have a good job. I will not be able to support my family. A person with panic disorder might have a thought like, if I drive on the highway, I'm going to have a panic attack. I may pass out and crash the car. Emotional reasoning is where you reason from your feelings. Examples might be, I feel like a loser, so I must be a loser. I feel anxious, so I must be in danger. Many techniques to help people dispute and change their thinking are available. We try to help people make their thinking more compassionate. We teach them to talk to themselves like they would to a good friend, and more accurate, to think in ways that are more evidence-based, so that they are changing their thinking and making inroads on their suffering in a manner that feels like it has integrity. The truth, in individuals with painful disorders, will reduce not all suffering, but needless suffering. The third stage involves applying these skills, especially the revised ways of thinking and perceiving, to their life situations. There is a particular emphasis on disentangling the behavior patterns that reinforce the needless suffering, the withdrawal out of discouragement, the avoidance out of fear, the behavior patterns that have kept the person stuck and prevented them from realizing important life goals. Near the end of treatment, we teach and have clients practice relapse prevention skills to deal with possible recurrence of symptoms in the future. We acknowledge, even celebrate the progress that has been achieved, but also encourage clients to continue working on their coping skills so as to prevent relapse and foster personal growth. If you want to learn more about cognitive therapy and the disorders that it can effectively treat, there are many resources on the web. Because the treatment model is clear-cut, it has generated a good deal of self-help books and other useful tools. You're certainly invited to go to our website, the Washington Center for Cognitive Therapy.com, that has links to many of these helpful resources. Thank you.